establish a basis about the behavior of metastatic colorectal cancer, it has been tough to incorporate biomarkers to treat our metastatic CRC patients just because of the main features of colorectal cancer. This is a super heterogeneous tumor, what it means that we may find several molecular alterations, tumor mutations that can coexist all together and can change, guaranteeing clonal evolution once we are starting a targeted therapy. What it means in colorectal cancer, anti-EGFR therapies for all RAS, BRAF wild type, BRAF inhibitors, and then we have other coexistence, for example, together with MSI high status. So heterogeneity it's very complex in colorectal. We know that this is a genomic illness, and one of the biggest problems in metastatic colorectal cancer is that the founder genes that warrant the carcinogenesis, what it means APC, the Wnt beta-catenin pathway, have been until now undruggable, what it means a problem. And then we have the problem of biomarker determination. We learned that in patients with RAS-BRAF wild type right-sided tumors, the response to anti-EGFR therapies is not that good as for left-sided tumors, but we still don't understand why. So we have a limitation to test particular biomarkers, and we still have to learn a lot about the underlying biology of colorectal cancer. But the data that Professor Ciardello has presented today and the studies that I'm going to present are the translation of how relevant it is to understand the tumor biology of colorectal cancer to build new drugs, new compounds in this disease. So I mentioned at the very beginning that I'm going to focus on heavily pretreated population. So here you have a picture of the ESMO, updated ESMO guidelines of colorectal cancer. So the molecular profiles of colorectal cancers now are known as RAS-BRAF wild type CRC patients, tumors harboring RAS mutations, tumor harboring BRAF mutations, or MSI high patients that as I mentioned before, I'm not going to cover. So now we have plenty of options for this patient population. It is recommended in the third line to test the HER2 overexpression, trying to find eligibility for clinical trial or the possibility, if accessible, to treat these patients with HER2 targeted therapy. And for these patients, since third line and beyond, we have trifluridine BEP. I agree with Professor Ciardello, this is the standard third line of treatment, but we have other options in the third line, like is the case of fruquintinib, or other drugs like regorafenib, or the potential of re-challenge in patients with RAS-BRAF wild type tumor. So let me start with this particular patient profile, patients with RAS-BRAF wild type tumors. So this year, it has been very important to cover this particular treatment strategy, the re-challenge. Remember that re-challenge is for those patients that are RAS-BRAF wild type. They were treated in a past time point with an anti-EGFR therapies. They presented a partial response or a prolonged stable disease. Then they have a progression on treatment, and with a washout period, we try to restart again with the anti-EGFR. So we try to re-challenge the patient once we confirm that there was a progression on treatment with anti-EGFR. This would be the strict definition of re-challenge. So I'm going to cover the CITRIX study because this is we had at ESMO this year the presentation of all the data of CITRIX study. This is the first randomized clinical trial in the third line setting of metastatic colorectal cancer, RAS-BRAF wild type tumor. This is a study led by the group of Clara Montagut in Spain. And a nice thing of this study is how patients were selected to be in. So the test was NGS testing in liquid biopsy, and the inclusion criteria was based on the relative mutant allele fraction. So we have the determination of several driver genes. We identify the resistance mutation, and we compare the weight of the resistance mutations compared to the one of the driver genes. They didn't present this at ESMO, but as I mentioned, we have been involved as investigators in this study, and this is a smart way to select patients for re-challenge. So patients were randomized 1-to-1 to receive irinotecan cetuximab or the investigator choice at that time point when we still didn't have the access to trifluridine BEP. So in the majority of the cases, as you will see later on, we have other treatment options different from trifluridine bevacizumab. So at the end, 800 patients were eligible for the screening, 58 patients included, 31 patients were treated with irinotecan cetuximab and 27 with investigator choice. As you can see here described, the proportion of patients receiving trifluidine-tipiracil-bev was quite low, but this is quite usual considering the time point, as I mentioned before, when the study was developed. We have other treatment options like capecitabine combined or not with bevacizumab or regorafenib. Of note, in Spain, we have restricted access to regorafenib in several areas of the country. And here you can see the bottom of the slide the different the NGS testing that was performed in this particular clinical trial. Regarding the patient features, I would highlight that for those patients included in the cetuximab irinotecan rechallenge strategy, more patients had complete response or partial response in the frontline therapy, and more patients have a prolonged washout period in the group of cetuximab and irinotecan treatment arms. But globally, the patient features were balanced. Here you have a summary of the efficacy in the clinical trial. So as you can see, although the small numbers turns into the lack of statistically significance, we can see that the rechallenge with irinotecan cetuximab showed a higher response rate and disease control rate. The current disease control rate was 77% compared with 44% for investigator choice. In regards to progression-free survival, it was 4.6 months compared to 2 months, so numerically superior, favoring cetuximab irinotecan rechallenge. In terms of overall survival, you can see that the small numbers make it difficult to find, as mentioned before, statistically significance, and of note, there was a 75% crossover rate. It's important as well to understand the context at our country, that we don't have the possibility or we don't have the reimbursement of liquid biopsy to check eligibility for rechallenge. That's why it was a huge opportunity for the investigators to identify potential patients that later on could receive an anti-EGFR rechallenge. Consider that if the patients are treated into the control arm, then we have more time for a washout period, and probably we have more chance to have responses to anti-EGFR in later lines of treatment. And here you can see that although the limitation of the small numbers of patients treated with trifluidine-tipiracil-bev, there is also a trend to have better outcomes in those patients treated with the anti-EGFR rechallenge. To me, this is the most interesting data, I would say, because for those patients that were considered ultra-selected, the definition of ultra-selection is described here without showing any mutation concerning not only KRAS and RAS, but the receptor BRAF MAPE2K1, that it's in the MAP kinase pathway together with HER2, MET. In these all wild-type patients, the benefit of the treatment was higher than for those that have any gene alteration. So this is as well coherent with the phenomenon that we are seeing in the frontline setting. So this is a different topic if we have to redefine the way in which we are selecting patients eligible for an anti-EGFR treatment, not only in the refractory setting, but as well in the frontline. So as a summary and conclusions and food for thought about CITRIC, I would say that ctDNA represents a biomarker strategy to guide EGFR reintroduction rechallenge, as liquid biopsy enables the longitudinal and minimally invasive tracking of tumor evolution, so that it's a way to capture the heterogeneity and dynamic nature of metastatic colorectal cancer across lesions. The CITRIC trial demonstrates the potential benefit in terms of progression-free survival and overall response rate of this treatment strategy, and must be guided by liquid biopsy. And the results are aligned with the Parere trial. Remember that this was a study that evaluated the sequence of panitumumab, regorafenib, or the reverse sequence guided by liquid biopsy, or the data that we as well as VHAO presented at ESMO, in which we selected as well patients based on the relative mutant allele fraction that really helps to identify extra patients for this treatment strategy. But at the end, a bottom message is that we have to think and to harmonize the assays that we are using to test the mutant allele fraction and try to find an ideal threshold in order to define patient eligibility for this particular clinical trial.